So with chapter 14, we are talking about disease outbreaks and pandemics. So this chapter focuses on the core steps used to detect, investigate, and control communicable disease outbreaks using 4 real-world examples. First, the COVID-19 pandemic illustrates large-scale public health response and mitigation strategies. Second, outbreaks of carbapenem-resistant Enterobacteriaceae, or CRE, linked to contaminated duodenoscopes, show how healthcare-associated infections are detected and prevented. Third, a wound botulism outbreak among injection drug users demonstrates how the essential public health services can guide an outbreak response. And finally, coccidiomycosis or valley fever highlights how public health addresses occupational exposure to environmental pathogens. Together, these cases show how outbreak principles apply across different settings. So as you may recall, COVID-19's pandemic began in December of 2019 with a cluster of unexplained pneumonia cases in Wuhan, China. By late January 2020, the first U.S. case was confirmed, and within weeks, the U.S. had declared a public health emergency. In March, the WHO declared a global pandemic. Early on, testing wasn't available, so public health relied on syndromic surveillance, tracking severe pneumonia, conducting case interviews, and identifying travel risks. Once testing became available, criteria focused on travelers from Wuhan and close contacts of confirmed cases. Screening at airports and surveillance of ICU admissions and deaths helped to detect the spread. As the pandemic evolved, new challenges emerged, including MIS-C in children and severe impacts in nursing homes and high-density workplaces. And this all required the expanded surveillance and infection control. Outbreak investigations during COVID-19 required tight coordination between epidemiologists, environmental health, nurses, and physicians. Teams that analyzed transmission data, assessed ventilation and workplace conditions, and implemented infection control measures. High-risk settings like schools, colleges, correctional facilities, work sites, and shelters required tailored protocols and health officer orders. Public Public health mobilized partnerships across the entire community. Healthcare systems, businesses, schools, first responders, congregate living facilities all worked together. Early control relied heavily on behavioral and environmental measures like masking, isolation, quarantine, distancing, hygiene, and cleaning. Enforcement was also critical. Health officer orders were backed by inspections and compliance efforts, and violations were publicly reported to reinforce accountability. Connecting people to services was critical during COVID-19, especially for isolation and quarantine. Counties activated 211 lines to link residents to healthcare, food, and mental health services. Telehealth expanded rapidly while elective procedures were delayed to preserve surge capacity. Providers received frequent health alerts to guide response planning. A competent public health workforce was essential. Staff conducted case interviews, identified risk factors, built investigation tools, and analyzed large volumes of data, including tracking cases, hospitalizations, deaths, and positivity rates. These data directly informed health officer orders and surge planning. Public dashboards posted case rates, outbreak locations, skilled nursing facility data, and vaccination coverage. Teams across epidemiology, labs, IT, environmental health, and outbreak management worked continuously with a strong emphasis on equity, using data to target the hardest hit communities and guide protective interventions. CRE became a major concern when outbreaks were linked to ERCP procedures, endoscopy procedures. Investigations found that even when cleaning protocols were followed, the complex design of the duodenoscope, especially the elevator channel, made complete disinfection very difficult, allowing resistant bacteria to spread. In Los Angeles County, CRE was added to the to the list of reportable conditions to strengthen surveillance efforts. In 2015, a hospital infection preventionist reported a cluster of carbapenem-resistant Klebsiella pneumonia cases following ERCP procedures. Public Health launched an investigation after an infectious disease physician had earlier flagged an unusual post-procedure bacteremia case. Review of 2014 data identified 33 CRE cases, with 23 of them being CRKP. The hospital conducted detailed chart reviews, assessed room locations, directly observed scope reprocessing, and performed molecular testing to determine genetic relatedness and identify a point source. What's interesting is that some of the isolates tested negative for carbapenemase genes, highlighting the complexity of resistance patterns. In this outbreak, 15 patients met the case definition. A case was defined as any patient who is CRKP OXA 232 culture positive, whether they were infected or colonized, after undergoing an ERCP between October 2014 and January 2015. Sadly, 3 of these patients died during the hospitalization. Early on, 8 cases were identified. Cultures came from blood and abdominal sources like abscesses and drainage. 7 isolates had identical resistance patterns, resistance to carbapenems and multiple other antibiotic classes, but still susceptible to colistin. 1 isolate that initially tested negative on multiplex PCR underwent whole genome sequencing, which identified the OXA 232 carbapenemase. Further molecular testing using rep-PCR and high-resolution melt analysis showed that strains were nearly identical. When investigators compared these highly related strains, the only shared exposure among patients was undergoing ERCP during their hospitalization, strongly implicating that procedure as the source. Investigators identified an index patient who is CRKP OXA 232 positive before undergoing ERCP in October of 2014. This patient had multiple procedures using 2 specific duodenoscopes, scopes 1 and 2, which were later established as a key risk factor for transmission. In total, 186 patients underwent ERCP with those scopes during the exposure window. All were notified by phone and letter about potential CRE exposure and offered rectal screening. Of the 150 patients screened, 7, about 5%, tested positive for CRKP, and those isolates were also OXA 232, confirming their linkage. The hospital responded aggressively. ERCP procedures were halted. The 2 implicated scopes were sequestered. Reprocessing practices were retained and reassessed, and all 7 adult ERCP scopes were cultured and reprocessed according to manufacturer guidance. They were also sent for additional ethylene oxide sterilization. A device report was submitted to the FDA. Ultimately, all 7 scopes cultured negative for CRE. Investigators conducted a site visit in 2015 to directly observe duodenoscope reprocessing. They reviewed cleaning and high-level disinfection procedures, confirmed that trained GI technicians and nurses were performing reprocessing, and noted that pre-cleaning occurred immediately after the procedures. The facility used an automated endoscope reprocessor and stored scopes appropriately. Following consultation with CDPH, CDC, and the FDA, the investigators alerted all acute care hospitals to initiate active and retrospective surveillance for CRE following ERCP procedures. Epidemiologic and laboratory findings suggested that the outbreak was multifactorial. The complex design of the duodenoscope, particularly the elevator mechanism, may have impeded effective cleaning. In 2016, the manufacturer recalled one model for modification. Enhanced measures were recommended, including double high-level disinfection, periodic culturing, and ethylene oxide sterilization. Guidance was reinforced by CDC, FDA, CDPH, APIC, and SHIA. Importantly, this outbreak demonstrated that even when guidelines are followed, device design flaws can permit MDRO transmission. Public health involvement at the county level was critical to scaling policy solutions and protecting patients across healthcare systems. In 2008, Los Angeles experienced a wound botulism outbreak among injection drug users. Normally, we would expect about 3 cases per year. However, 6 cases were identified within just 3 months. This was a clear signal that something unusual was occurring and that an outbreak investigation was warranted. Botulism is really rare, but extremely serious. It is a paralytic illness caused by the neurotoxin produced by Clostridium botulinum. It is considered a medical emergency. Because of its severity, suspected cases must be reported immediately to local and state public health authorities. For frontline staff like nurses and epidemiologists, this requires foundational knowledge. They must recognize the signs and symptoms, conduct surveillance and data analysis, identify epidemiological risk factors, understand appropriate laboratory testing, and implement preventive measures immediately. Importantly, they must also distinguish between the different forms of botulism, which would be wound, foodborne, adult intestinal, and infant botulism. At the supervisory level, public health leadership plays a strategic role. This includes interpreting data, allocating resources, developing control strategies, and determining whether additional response protocols are needed. This outbreak illustrates how core public health competencies from surveillance to strategic decision making are essential in detecting and responding to rare but high consequence diseases. In responding to the botulism outbreak, public health had to tailor strategies for multiple audiences. It wasn't just about identifying cases, it was about educating those at risk and professionals serving them. That meant developing targeted outreach for healthcare providers, homeless outreach workers, public health center staff, mental health providers, and even the police. At the frontline level, public health nurses and health educators created training materials for field teams and developed posters and educational flyers for community members and stakeholders. At the supervisory level, leadership reviewed and improved key messaging for training, health alerts, and press releases, which were especially important because botulism is rare and easily missed. They also ensured guidance emphasized early treatment with botulism antitoxin, which clinically suspected, even before lab confirmation was available. Finally, partnerships were critical. Public health collaborated with substance use treatment centers, needle exchange programs, homeless outreach teams, mental health providers, and law enforcement to expand education and prevent additional cases. This response highlights how effective outbreak control depends on clear messaging, coordinated leadership, and strong community partnerships. One of the most challenging aspects of this outbreak was messaging to people who inject drugs. Public health had to clearly communicate the risks of wound botulism while recognizing that individuals were unlikely to stop injecting in the short term. That required a harm reduction approach rather than a purely abstinence message. Frontline staff provided essential feedback from the field about what messaging worked, what didn't, and how to conduct outreach effectively. Supervisory staff had to confront structural bias and social inequities that could undermine the response, while ensuring organizational policies aligned with community-centered goals. Field outreach teams included public health workers, homeless outreach teams, and police, primarily for safety and local insight into where education efforts would be most effective. Healthcare workers needed strong interviewing skills, rapid training capacity, and data collection tools to evaluate impact. They were able to track who is reached, housing status, language needs, and prior awareness of botulism and willingness to engage. This response illustrates how outbreak control depends not just on science, but on equity, trust, and practical community engagement. To evaluate the effectiveness of the outbreak response, the team measured how quickly botulism antitoxin was released and how fast patient interviews were conducted to identify epidemiologic risks. Field data and ongoing surveillance were analyzed to look for additional cases. Because botulism can progress rapidly, with respiratory failure possible within 2 days, speed was critical. Frontline staff reviewed suspected cases immediately and deployed into the field to conduct interviews before patients clinically deteriorated. National data show how serious botulism can be. Nearly half of hospitalized patients in one CDC review required intubation, reinforcing the urgency of early detection and action. Supervisory staff continuously refined interview tools to capture emerging risk factors, and ultimately, all cases were interviewed. Importantly, outreach efforts were effective. Over 80% of individuals engaged verbally during education encounters, awareness increased over time, and surveillance for the remainder of the year did not identify any additional clusters. This all demonstrates how rapid response, strong surveillance, and targeted outreach can successfully contain a high-risk outbreak. Valley fever, also known as coccidioidomycosis, is a fungal disease caused by inhaling spores that live in the soil. It is endemic in parts of California, including northern Los Angeles County and the Central Valley. Most people have mild or no symptoms, but some people develop severe pneumonia or even disseminated disease. Exposure happens when the soil is disrupted, disturbed, often during outdoor or occupational activities. Because of this risk, cases are legally reportable under California regulations. Physicians must notify the local health officer, and if the illness is work-related, they must submit a doctor's first report for occupational surveillance. In this outbreak, public health was alerted after 2 occupational reports were filed for individuals who worked on an outdoor television shoot in Simi Valley, a known high-risk area. That notification triggered an investigation into a cluster among crew members exposed during on-location filming. The outbreak investigation was comprehensive. Investigators reviewed medical records, employer rosters, occupational surveillance reports, social media posts, and conducted interviews with cases, the employer, and the site manager as well. They also analyzed county communicable disease surveillance data sets to look at demographics, lab results, and prior case interview notes. A confirmed case required lab confirmation plus compatible symptoms in someone present at the filming event. A probable case was clinically compatible illness without lab confirmation. In total, 5 confirmed and 5 probable cases were linked to the shoot. Surveillance was critical. 8 of the 10 cases were identified through occupational injury reports. One case was found through a social media post about hospitalization, which led to identifying another exposed visitor. With 655 workers on the roster, the overall attack rate was about 1.5%. Looking at the epidemiologic links, most cases were male with a median age of 37. Half of them were actors and others worked in camera, sound, set construction, or were visitors. Symptoms developed an average about 7 days after exposure. Interestingly, only 2 people directly disrupted soil, but many were shuttled on dusty ranch roads, and most reported dry, dusty conditions during filming, suggesting that airborne exposure was the likely route. In terms of prevention, this outbreak underscores occupational risk from environmental pathogens. Risk reduction focuses on 2 areas: education and dust control. Clinicians were encouraged to ask about occupational exposure, and work sites implemented dust suppression, employee training, and enforcement of injury and illness prevention programs with respiratory protection. Finally, innovative surveillance made a difference. Reviewing occupational injury reports identified the outbreak, something traditional surveillance might have missed. Social media even helped detect additional cases. While there was some reporting lag, this approach highlighted new at risk industries and demonstrated the power of non traditional data sources.